regardless of the surgical procedure that we're about to perform, it would be appropriate to go through the technical aspect of sterilizing your field. And the surgical canine does allow that by this abdominal skin plate. This has the same realistic texture as well as anatomy as real skin. And so before we do the procedure, it would be appropriate for the technician or the training veterinarian to go through this procedure of doing 3 scrubs to try to, again, mimic the proper protocol prior to actually doing the surgery. So we're going to go ahead and assume that's been done here and that this is prepped and ready to go. At this point, we're going to perform an OVH. We're going to start by draping the abdomen. We go ahead and place the drape so that the umbilicus is just in the cranial aspect of your drape. And we're going to towel clamp it in appropriately. Next, we're going to go ahead and make our incision. The incision is made approximately 4 centimeters below the umbilicus, which is marked here, and extending caudally. At this point, I'm using a 10 blade. You could use a 15. You then can dissect down. You can visualize the muscle and dissect down to the linea alba. There is a fascia plane here. And looking, you can see the linea. And what I do, I'm going to tent this and open the linea, exposing the abdomen. You can see the abdominal musculature, and you have the fascia as well as the skin. And then, of course, the internal striations of the muscle within the abdomen. At this stage, we're going to go ahead and take the spay hook and sweep medially, trying to capture the broad ligament and get that uterine horn so that we can exteriorize the reproductive tract. So we have it. So you can see the broad ligament and your uterine horn. And we track it cranially. It's under tension by the suspensory ligament. And there is the ovary. So the way I like to do it next is taking a hemostat. I like to grab hold of the caudal aspect. Right at that tendinous insertion, and then you can just see the ovary exposed here. You then reach down on the suspensory ligament, strum caudally until you can snap it, allowing exteriorization of the ovary and the pedicle. Note the vasculature, as well as the vasculature on the broad ligament. And we're going to now go ahead, clamp these off, and do the ligation. make a window. You can see your vasculature here. You make your window in the broad ligament, and then a clamp. I like to use Carmel's. And I'm old school, so I'd like to do 3. Clips. And then I make my cut between the most, I guess, proximal to me, between the hemostat there. So now we have the ovary and the pedicle's been ligated, and we're going to strip down the broad ligament, retracting the uterine horn, and lay that back. So what we've done here is ligated the pedicle, and if done properly, there should be no bleeding. But since this is a sibulator and we have the capability of, kind of creating error to best learn, I wanted to also demonstrate what would happen if you removed your clamps or if you happen to drop your pedicle by removing our clamps and then visualizing the bleeding. So as you can see, hemorrhaging does occur. And with that, you could have a crisis situation that would have to be corrected. Now that we have this crushed with the Carmel's, I'm going to ligate it. Of course, I use a 3 transfixion. I use a 3 tie ligation, and I use a Miller's knot. Some people will do a transfixion or a surgeon's knot. My initial tie. Again, you can use any size suture that you deem appropriate. In this case, I'm using 2/0. And of course, as we all know, we want to place our throw, and then I'll release. I think I'll do a surgeon's for this. Mild tension, and then I'll release this one to create a groove by which I can then tighten that down. I'll just do a 1/3 for security. But if you're confident in your ligation, 2 should be sufficient. Now, just grasp the pedicle, release, check for bleeding. Looks good. Then you return that to the abdomen. And then grasping the uterine horn, we're going to strum the broad ligament caudally until we find the bifurcation at the uterine body. Right. I think, again, sometimes you can use your spay hook to acquire the other horn. In this case, oh, here I feel it, here I feel it. And so we would come down, tracking this until we find the ovary. at which point we can achieve the same procedure on this end. Repeat the procedure as done for the left ovarian horn. So we've exteriorized the uterine horns, and we pull up to reveal the uterine body. So you can see. So at this juncture, we pull it up and place a carmalt just above the cervix. And then I follow up with two more clamps. Ligating or occluding the uterine vessels. At this juncture, you could then do a transfixion ligature. I'm going to go ahead and remove the rear tract first by cutting between the first and second carmalts. Getting this out of the way. So this is the reproductive tract, which now is set aside. The uterine body will now be transfixed with a ligature. And this transfixion ligature will prevent slippage. In this case, I'm going to go to both the left and the right, creating two transfixion ligatures. And then we're going to do a compression ligature, like a Miller's knot, or you could do a surgeon's knot to ligate these vessels. That. All right. So then what I like to do after that is, after placing the two separate transfixion ligatures, is doing a Miller's knot, or any other throw. Removing that clamp, and then sinking this into the groove, thereby properly occluding the vasculature. You can put another ligature there. Let's go ahead and see if this was sufficient. In this case, I'll probably use a small mosquito hemostat, and grasping the, kind of let that go in. Check for bleeding. Seems to be doing well. And then you can release that into the abdomen. So at this point, it would be appropriate to evaluate if there's any internal bleeding, if you want to be very thorough, by taking gauze or a towel and kind of dabbing. You see very minimal blood was spilt during the procedure. And then you can check the gutters and such to see that all is well. We then would close routinely in the, of course, first the linea alba, the subcutaneous, and then the skin. I'll demonstrate that later on the skin plate.